Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Faiza Naeem. I'm working as a registrar in Rheumatology Department of Shalimar Institute of Health Sciences, Lahore. I'm going to present a case of juvenile osteoporosis of an 18-year young girl with a history of 3 spontaneous fractures. First fracture of right femur at age of 7 years. Second fracture of left supracondylar region of femur in February 2015 at age of 10 years. She had third fracture of right proximal femur in March 2022 at age of 18 years while taking alendronate since 2015. She has no background history of trauma, surgery, infection, thyroid dysfunction, growth retardation, connective tissue disorders, diabetes, renal disease, anorexia nervosa, no use of steroids, immunosuppression, and anti-epileptic drugs. Clinical and morphological features are not suggestive of skeletal dysplasias or osteogenesis imperfecta. She is blind by birth with no history of birth complications, normal developmental milestone. She has weight of 55 kg and height of 4.7 feet. Age of menarche is 13 years with good IQ level. She is regularly taking calcium and vitamin D supplements along with weekly alendronate, 70 milligrams since 2015. Her lab reviews shows a low vitamin D level initially and low insulin growth factor, but the rest of metabolic and endocrine profile was normal. Her DEXA scan was done in 2016 March, which showed total Z-score of lumbar spine minus 4.8. And in September 2016, total Z-score of lumbar spine was minus 2.9. In October 2018, total Z-score of lumbar spine was minus 1.7. And in May 2021, total Z-score of lumbar spine was minus 2.6, and total Z-score of whole body was minus 3.5. Unfortunately, I could not get her radiology film. I just have remarks by radiologist. Her thoracolumbar spine X-ray was done in 2015 when she had second fracture. T12 to L1 vertebra was biconcave with reduced bone density and end plate sclerosis. Vertebral bodies show partial collapse with intact end plates and disc. MRI was done at the same time, which showed codfish spine suggestive of severe juvenile osteoporosis. Her X-ray thoracolumbar spine was repeated in 2022, which showed concave-shaped vertebrae with thick sclerosed end plates and intact intervertebral disc spaces. Her skeletal survey of skull, chest, pelvis, bilateral hands, and long bone was unremarkable, which was done in 2022. So in short, this patient has 3 spontaneous fractures, first one at the age of 7 years, and the last one, recent one, was in March 2022, while she was taking alendronate since 2015. We did not find any secondary cause so far. Her lab showed low vitamin D initially, but her rest of metabolic and endocrine profile was normal. Severe osteoporosis on DEXA, partial collapse, and codfish vertebra on radiology. We are here to discuss whether we are missing to rule out some secondary cause or any other differential diagnosis. Is it purely juvenile idiopathic osteoporosis? And treatment option we can offer to our patient now. Thank you.
Thanks for that really interesting case. So clearly, this is really abnormal. So the things that are striking about this is the fracture. One question I have is the fractures were due to falls or not? No. So they're non-traumatic fractures. So that 3 non-traumatic fractures is really quite unusual. So the things that I think about are nutritional deficiencies and then endocrine or metabolic abnormalities, and then genetic causes for low bone density. So, in terms of like a juvenile idiopathic osteoporosis, like that's sure, I guess the category that you could cause it, because we don't call it, because we don't know what's going on. But I think surely like a nutritional deficiency would have shown a little bit more of abnormalities other than the low vitamin D, and you're repleting the vitamin D, so I don't think that's quite the direction that we would go. Also, it doesn't usually show up with pathologic fractures in kids. It's more rickets, which she didn't have at age 7. From the endocrinology side, that lab slide was up quite quickly, but it didn't look like there were any like calcium, magnesium, phosphate, so you could kind of go down those really tricky pseudo-hypoparathyroid, but it didn't look like any of those were kind of the path to go. And so the last category that I think of is inherited causes of low bone density. So, there's a lot of different categories for this, but I think of some of the mild forms of osteogenesis imperfecta. Did she have any blue sclera or anything on exam like that? Usually you have more fractures and the phenotype is a little bit more severe. But then there are some other disorders of collagen which can be milder. Some of the Ehlers-Danlos classes, you can have multiple pathologic fractures. There's a couple other, did she have stretchy skin or any hypermobility? No. So those phenotypes can be really mild, and I would consider discussing her with a geneticist and maybe going for some targeted sequencing in her, because if it's not metabolic, repleting calcium and vitamin D isn't going to help, and there might be other guidelines, but it might depend on the etiology. I don't know if anybody else has other thoughts.
You were quite right, Laura. The endocrine slide came out quite quickly. But have you ruled out osteomalacia? What was her calcium and what were her alkaline phosphatase levels? We can't hear. I think you have to turn it on.
This patient was referred from endocrinology department, and they have not mentioned the evidence of osteomalacia at that time when she presented to endocrinology department. And second, her eye examination was done by ophthalmologist for osteogenesis imperfecta. It was absolutely normal.
Because in my library, codfish vertebra is osteomalacia, and the fractures could be pseudo-fractures. And you just need to look for a raised alkaline phosphatase and reduced calcium. I don't think you told us what her PTH level was.
No. It was normal, sir. Alkaline phosphatase, phosphorus, and serum calcium was always normal since 2015. Only vitamin D was low in 2015, and after the supplementation, it was normal in all labs.
And I quite agree with Laura here, but I think the most common issue that I get in the clinic is the parents and the person always says, no, I don't have an eating disorder, but does she have anorexia, and does she have an eating disorder, and is this nutritional?
Sir, I have taken detailed history about anorexia nervosa, and I did not find any history regarding nutritional deficiency or...
what was her BMI, for example? Was her weight normal?
Sorry?
And just leading on from that, the treatment for anorexia nervosa induced osteoporosis and fractures, and this is what it is lifestyle rather than alendronic acid.
Okay, thank you so much. Now we will move on. Yes. Yes.
So I think where we work, and Laura can concur with us, is that we get a lot of patients where we have no idea what's going on, and it's very complicated because probably we have like an undiagnosed disease program where anybody in the US who is not able to get a diagnosis gets sent to us. So I think in those cases when we get consulted, because rheumatology, they consult us a lot, is that we kind of have to step back a little bit. And instead of focusing on you have to kind of focus more on a system. So you have to see whether it's a metabolic system that is causing a problem, is this a structural or a genetic reason, and then sort of take an approach. So if the metabolic processes are all, or endocrine and metabolic is normal, then there must be a structural problem in the collagens that is leading to so then the structural problem most commonly in somebody young like that is probably a genetic cause. So I think I would agree with what Laura is saying. They're probably doing a whole exome sequencing or a targeted sequencing probably be the best thing to do if metabolic, what John was saying, is all been ruled out.
Thank you so much. Now we will just move on to our last case. Dr. Shamsuddin, who's a fellow rheumatology at Central Park Teaching Hospital, will be presenting this case to you. Thank you.
Assalamu alaikum. I'm Dr. Shamsuddin, fellow in the Department of Rheumatology, Central Park Medical College. I'll be presenting this case of a patient with rash and proteinuria in a young male. So 17-year-old male had a history of fever and a rash on face for 1 year and body swellings also for 1 year. He also had frothy urine, periorbital puffiness and pedal edema. On examination, there was pallor, hyperpigmented rash on the nose and cheeks, pedal edema and ascites. His labs showed normocytic anemia with hemoglobin of 12, ESR was of 90 millimeters in first hour. Urine complete showed proteinuria of 3+. There was no blood, no cast, and on quantification, 24-hour urinary protein was 4.5 gram with normal serum creatinine and estimated GFR. His serum albumin was 1.7 gram per deciliter. His serum ACE level and corrected calcium were normal with reduced 25-hydroxy vitamin D levels. So for the rash, dermatology planned biopsy, which showed the non-caseating granulomatous inflammation. His autoimmune workup before the biopsy, which was done, which showed ANA positive with 1:80 in speckle pattern. Anti-dsDNA was negative. Anti-SSA was positive in quantity of 100. Low C3 and low C4 levels. His CT chest showed bilateral axillary and mediastinal lymphadenopathy. Renal biopsy was done, and it showed membranous glomerulonephritis. Immunofluorescence assay showed +1 staining for IgG and C3 only. Electron microscopy was not available. So this is the picture of the rash on the nose and the cheeks. So this is the picture of renal biopsy, and this is the skin biopsy, which showed non-caseating granulomatous inflammation. So the diagnostic challenges in this patient, the lupus pernio, bilateral mediastinal lymphadenopathy, and non-caseating granulomatous inflammation, which favor the secondary sarcoidosis with secondary membranous glomerulonephritis. He was having fever, alopecia, ANA positive, and Rho positive, which for the class 5 lupus nephritis. It could be the sarcoidosis and the primary membranous glomerulonephritis. So we had difficult to diagnose nephritis along with these features.
Thank you, Dr. Shams. So there was some diagnostic challenge as well. Whenever you see a patient who has a rash, fever, which is a facial rash in a distribution which was malar, and a young boy with proteinuria, so the first thing came to mind was lupus and nothing else. But our dermatology colleague were insisting that this rash is not typical of lupus. This is something like lupus perniosis. This rash which you have seen is actually the one which was treated, and they had actually been following him in the dermatology clinic. So when the biopsy was done, and it revealed a non-caseating granulomas as well from the pinna, which he was having a rash there as well. But the dilemma remains that the positive ANA, a positive Rho, a low complement C3, and a biopsy suggestive of class 5 disease. But on IFA, the biopsy didn't reveal anything other than just a mildly positive IgG in the mesengium. So finally we came to this, that this young boy possibly has sarcoidosis with secondary membranous GN. But as such, we didn't had much of a therapeutic challenge because in any case, we had to treat him with steroids, and he was put on mycophenolate mofetil, and down 3-6 months, he's really did very well. His class 5, his as membranous point of view, he's in partial remission now, and he's doing well. So any questions? And we would like whether you have seen patients who have sarcoidosis and positivity of a row or association of two autoimmune diseases occurring together. Like even we thought about Sjogren's initially, so secondary Sjogren's with lupus, or sarcoidosis being coexisting with lupus in this young one. I think Sarfraz, so you...
We've got 2 lupus experts here.
Yeah, Sarfraz.
I'll throw in my bit, and then the experts can sort of join in. But you've got a bit of both, haven't you? So you've got a bit of sarcoidosis and the bilateral lymphadenopathy, and the sarcoid facial rash, which was proven by biopsy. But you've also got somebody with nephrotic syndrome, with raised SSA, I think it was, and a clinical suspicion of Sjogren's syndrome and nephrotic syndrome and membranous glomerulonephritis. I've actually just looked up in up-to-date because I wasn't aware of how common glomerulonephritis was in sarcoid, but membranous is reported, but it's uncommon. My colleagues.
So, will he meet criteria for Sjogren's syndrome or not? Will he meet the criteria for Sjogren's syndrome? Will he meet the criteria for Sjogren's syndrome? I mean, serologically, you have met the criteria, but clinically, is there any criteria that?
So he didn't have any history of a dry mouth, dry eyes, and didn't have any decreased fear or celebratory on examination.
So just one question. His complements were low as well, which we see mostly in the lupus cases. So, and we've gone through some literature review as well. In sarcoidosis, they actually say the complements are usually normal. So that's also a difficult part to correlate with this case. So that's what I'm wondering.
So if maybe I can just say one thing real quick, and then let others say. So. So having kidney involvement like this with the positive serologies of SSA, that is not uncommon. So in fact, we have patients like this in our own cohort. We have, in fact, one patient comes to my mind who is exactly the same, except one issue here is the skin problem. So skin you cannot combine, but everything else speaks for Sjogren's. But of course, there are cases where the autoimmune diseases overlap. So could it be that it's both, you have some of the features for Sjogren's and then some of the features associated with sarcoidosis. And because we try to box diseases into one category, but of course the underlying process is the dysfunctional immune system. And it can have multiple flavors, so maybe it is manifesting as both sarcoid and Sjogren's type presentation,
And you wouldn't be too worried that ACE was normal?
Yeah, actually we reviewed literature, and there were some case reports, sarcoidosis and SLE and sarcoidosis and Sjogren, actually more for the Sjogren. So interesting case.
One more thing. So on the biopsy, did the or renal people feel like it was really good? Because sometimes with sarcoid, I have seen a couple of cases of sarcoid involving the kidney. I had a lot of sarcoid where I trained at Duke. But sometimes we could see the granulomas on kidney as well. Did they feel like the biopsy was like good, there was a lot of gloms, or did they think it was kind of not such a great biopsy?
Yeah, so there was no granuloma in his case, but it's just like membranous, but with not full house effect as we see in lupus.
Yeah.
So again, more favoring sarcoidosis for that reason, yeah.
And did he have an eye exam to look for the eye findings in sarcoid?
Yeah,
and that was negative.
he had, it was all fine, yeah.
Thank you so much.
Thank you so much.
Thank you, the professors, Dr. Hasni.
Great cases, well done.
Dr. Exford, Dr. Lewandowski, and Dr. Salman. Thank you so much for your time. Now we will end our Meet the Professor session, and I will pass over the controls to the stage secretaries, Hadi and Noor, to start our session on rheumatoid arthritis. Thank you very much.
Greetings and Assalamu alaikum. My name is Hadi Hassan Khan and I'm a second year MBBS student in Shalimar Medical College, and with me I have today
Assalamu alaikum. My name is Nurul Huda and I'm a second year MBBS student at Shalimar Medical and Dental College.
I'd like to welcome you all as we begin day 2 of the 25th Annual International Rheumatology Conference. After the enlightening discussions held on day 1, topics varying from SLE and APLS to scleroderma and sarcoidosis, today's sessions will tackle topics including rheumatoid arthritis, spondyloarthritis, and ID rheumatology, presented by experienced physicians with immense expertise in their fields.
Before we proceed, I'd like to ask the audience to kindly switch off your mobile phones to avoid any disturbances. Please also note that you may write any questions you have on the question cards that are being handed out, and we will open the floor for questions at the end of the session.
Today's first session, the 4th session of the conference, will discuss rheumatoid arthritis, and I'm honored to announce that this session is dedicated to Professor Dr. Abid Farooqi, the 4th President of the Pakistan Society for Rheumatology from 2005 to 2007.
Before we begin, let us introduce our honorable chairs for this session. We have Professor Dr. Salima Zaman Azmi, who is the Associate Professor and Head of Pulmonology Department at Shalimar Medical and Dental College, Lahore. Professor Dr. Naeem Afzal, who is a Professor of Medicine at Fatima Jinnah Medical University, Lahore. Dr. Lubna Nazeed, Assistant Professor at Liaquat National Hospital. Dr. Uzma Rashid, who is a Consultant Rheumatologist currently practicing at Maroof Hospital, Islamabad. Kindly, I would appreciate if you all would come on the stage.
The first speaker for this session is Dr. Babar Salim, who is currently an Associate Professor of Rheumatology at Fauji Foundation Hospital, Rawalpindi. I'd like to invite Dr. Salim onto the stage to speak about the diagnostic challenges in rheumatoid arthritis.
Assalamu alaikum. Well, my presentation is going to be more of a revision, and as my Ustad-e Muhtaram, Professor Abid Farooqi, I really like his word, it is more of a gupshup. So he used this word when we used to listen his talks a long time ago, and this presentation is dedicated to the Ustad, the teacher of the teachers, Professor Abid Farooqi. And well, the topic I have been given is the diagnostic challenges in rheumatoid arthritis. This seems to be very simple, but when I was making the presentation, word by word, day by day, I found more challenges. And in my clinical practice, I also find sometimes a bit confused that is it really rheumatoid arthritis or not. So I'll start with the very basic concepts so that all the students and the people who are not the rheumatologists can cope up with the rest of the presentations as well. So the whole of my presentation is going to revolve around the following objectives: that do we have any diagnostic criteria for diagnosing rheumatoid arthritis? What is the role of rheumatoid RA factor and anti-CCP, which we daily in routine advise? Do we have any new autoantibodies? And any role of acute phase reactants? And do we have a role of musculoskeletal ultrasound in diagnosing rheumatoid arthritis? And a little bit about the typical and some atypical presentations of rheumatoid arthritis. So before we move on to my actual presentation, a brief, quick revision that what is arthritis, because jumping directly on the diagnosis of rheumatoid arthritis won't be appropriate for the non-rheumatologist. We need to know what is arthritis, and we all know, this is just a revision, that it is a combination of the swelling, stiffness, warmth, and redness, and we all know that it's not necessary that all these 4 features are always present to label a patient as arthritis. It's more of a combination of sometimes 2 symptoms, swelling and stiffness, sometimes warmth, sometimes redness. So it's a combination to make a diagnosis of arthritis. And once we know that this is arthritis, the next step we need to know that is it a monoarthritis? So involving a single joint, is it an oligoarthritis, or is it a polyarthritis? So we know that rheumatoid arthritis is a disease which usually involves polyarthritis. So, but when it's more of a diagnosis of exclusion. Once we know that the patient has polyarthritis, we need to rule out the other possibilities. For example, psoriatic arthritis, lupus, overlap syndromes, crystal arthropathies, connective tissue disorders, vasculitides, etc., and sometimes non-rheumatological diseases like in the form of paraneoplastic syndromes as well. So labeling a patient of rheumatoid arthritis, we have to rule out the other possibilities as well. So we are going to be dealing with a disease which is chronic, destructive, progressive, and multi-organ, and we know that the disease is not only confined to the joints only. It can involve any part of the body, no matter its eyes, lungs, skin, in the form of vasculitis. So we need to diagnose the disease as early as possible. These are all known facts. We don't have to go into the details. Patients with RA have a reduced quality of life. We all know this. Similarly, patients of RA suffer greater burden of work disability as compared to the general population. So we don't have to think more on these lines. We all know these facts. So coming to the rationale of my presentation is that 70% of the patients have an evidence of radiological damage within the first 1 to 2 years. So this is the critical window of opportunity. We have to diagnose the patients as early as possible, because if we don't diagnose them early, after 1 year, most of the patients will have some kind of radiological damage. And we know that most of the erosions, most of the damage is irreversible. So this was the local study by Dr. Saira and her team. This was published last year, and Dr. Saira, the convener of this conference, they did the study of 102 patients, and they found that the mean diagnostic delay was 1 year, and the diagnostic and the mean therapeutic delay was around 1.5 years. So that means that most of the patients after 1 year, we already know the data, that have already developed some kind of erosions and damage. And they also found that there was a significant correlation of the delayed diagnosis with the disease activity and disability index. So this is the rationale that we are diagnosing the patients late, no matter what could be the reason. Delayed referral, we are seeing not less patients are being referred to us. There are so many more reasons out of that. So let's see what American College of Rheumatology has to say about diagnosis. The very first principle, the very first guiding principle by the American College of Rheumatology is that RA requires early diagnosis, evaluation, and management. Now the question is, do we have any diagnostic criteria to diagnose a patient in our clinic? Well, the answer to this is, unfortunately, we do not have any diagnostic criteria, but we do have classification criteria. So what are the limitations of classification criteria? I'm going to talk about that. So this was the old criteria. When I was a medical student, we used to see all these things that we all know that 4 out of 7, we call it as, yes, the patient has diagnosis of rheumatoid arthritis. But remember, these are the classification criteria, not to be used for clinical practice. So in the old criteria, the problem was that it works really good in established rheumatoid arthritis. And in established rheumatoid arthritis, the specificity is more than 90%. But unfortunately, the sensitivity for picking the early rheumatoid arthritis is very low. That means if a patient is coming with an polyarthritis in an early stage, by using this criteria, you may miss more than 50% of the patients. So we need a new criteria. This is comparatively a new criteria published in 2010 by the ACR and ULAR. And this has a sensitivity of around 73% as compared to 47% of the previous criteria. I want to emphasize on the point that still they can miss around 25 to 30% of the patients who are coming up with early rheumatoid arthritis. So the catch point here is that these classification criteria are not designed to be used for the clinical practice. They are meant to be used for the research so that you can have a homogeneous cohort. So don't use them, don't print them and put it on your table, and when a patient comes and you start ticking that's the wrong approach. Use them for the research, not for making the diagnosis. So what do we have? The best diagnostic criteria is the clinical diagnosis by a rheumatologist and clinician, because it includes many more aspects. For example, it includes family history of rheumatoid arthritis, examination, exclusion of other possibilities, etc. I'll start with a simple case. This is the most typical case which we see in our clinical practice. A 22-year-old female has polyarthritis involving the small joints of the hand, elbows, shoulders. Nothing is suggestive of any alternate diagnosis, and there are no comorbidities. Examination, she has swollen PIPs, MCPs, right wrist is ankylosed, and there is a flexion deformity of the left elbow. Acute phase reactants are high, RA factor is positive, anti-CCP is positive. What is the likely diagnosis? This is a straightforward case of seropositive rheumatoid arthritis. So if the case is exactly the same, and RA factor is negative and anti-CCP is negative, we call it as seronegative rheumatoid arthritis. So we label a patient as seronegative when both the autoantibodies are negative. So don't label a patient on the basis of only RA factor negative with the positive anti-CCP. They both have to be negative to be labeled as a seronegative RA, and its prevalence is around 20 to 30%. And we all know that the sensitivity of RA factor and anti-CCP is comparable, but the specificity of anti-CCP antibody is much higher. Having said so, before ordering a patient for RA factor and anti-CCP, you should be clear-headed that why are you advising it? Because these autoantibodies can be present in huge number of other conditions, including the normal healthy individuals as well, in 5 to 10% of the patients. So you have to know why you are ordering these tests. Similarly, anti-CCP can be positive in a number of conditions as well in low titers, and even recently the data has published that COVID case baad bhi it can be positive as well. And this is a hype created term, long COVID. We all hear that the patient comes to you and they say that we had a COVID last year, but we still feel fatigue, we still have some kind of breathlessness. This is known as long COVID, and by definition, variable symptoms persisting or relapsing after a complete recovery from COVID. And the estimated prevalence is around 30%. And it has a huge number of symptoms, including fatigue, breathlessness, cough, myalgias, but what they have to do with rheumatology, there is a link. This was the updated APLA recommendations, which I was part of the authors as well. And we found that many case studies have shown that there is a positivity of ANA, RA factor, anti-CCP, etc. And documented proofs have been noted from various case reports that patients coming up with new onset of rheumatoid arthritis after COVID and sometimes myositis. But the point here is that is there a true relationship that do the patients really develop rheumatoid arthritis after COVID and COVID was the culprit, or it is just coincident? We still don't know, it's a limited data. So coming to the new autoantibodies in rheumatoid arthritis, there is a huge list of autoantibodies. I'll just want to highlight the first two antibodies, anti-carbamylated antibodies and anti-PAD4 antibodies, because their specificity is very, very high, and recently they have been shown that they have been associated with high disease activity, they correlate with the joint damage, and they are associated with the risk of developing rheumatoid arthritis. But the problem is they are not yet approved for routine screening. So don't use them, don't search that which lab is doing these tests in order to diagnose a patient for rheumatoid arthritis. So take home message from the case number 1 and 2, they are very typical that use RA factor and anti-CCP to support your clinical diagnosis. Sensitivity of RA factor and anti-CCP is comparable. The specificity of the RA is much higher. Many upcoming antibodies are in the process, but still not approved for routine screening. Treat patients, not the antibodies. This is the third case of a 33 years old male who has polyarthritis, and the patient is taking steroids. Everything is negative, suggesting of any alternate diagnosis. And ESR is quite high, anti-CCP is positive. Do you think that this patient has rheumatoid? Well, probably yes. Probably the patient has steroid masked rheumatoid arthritis, and it's a big challenge in our country because the patients are coming to us and they are taking some Hakimic medicines, they're all taking only steroids. History is very typical of that. They say that you have pain in the small joints, stiffness, and you don't find anything on examination. And in that case, we do take help from RA factor, anti-CCP, ESR, CRP, and musculoskeletal ultrasound as well. But having said so, we need to be aware of the limitations of all these tests. We have already talked about the limitations of RA factor and anti-CCP. Well, acute phase reactants, they can be normal in 35 to 45% of the patients with an active rheumatoid arthritis. So don't blame your laboratory person that how is it possible that the patient has an active RA and the acute phase reactants are normal. They can be normal in 1/3 to half of the patients. Coming to an ultrasound, this is the metacarpopharyngeal joint. We did an ultrasound. You can see small signals that show that probably the patient has synovitis, but the sensitivity is around 83% and the specificity is around 80%, which means still a musculoskeletal ultrasound can miss around 10 to 20% of the minimal synovitis. So please don't rely solely on the ultrasound. Ultrasound can miss minimal synovitis as well. So the take-home message from the case number 3 is that steroid-masked rheumatoid arthritis is definitely a very difficult diagnosis. So seek help from acute phase reactants, serology, and musculoskeletal ultrasound. 35 to 45% of the patients can have normal acute phase reactants, and even a musculoskeletal ultrasound can miss minimal synovitis. Case number 4 is about a 67 years old elderly female, has pain and stiffness in bilateral shoulders and left hip for more than 2 hours. So there's stiffness in elderly females and there's a pain in the left hip. Duration is only 1 month and there is no evidence of peripheral synovitis. On examination, the patient has a painful shoulder movements more on the right side as compared to the left, and there's a painful left hip movement. The rest of the examination is completely normal. We did an ultrasound. If you see the white dot surrounded by the black area, the white dot, that white area is the biceps tendon. It is surrounded by a halo, which is the biceps tendonitis. There is a fluid around the tendon, and on the right side, this is the hip joint, and hip joint is completely normal. And as per the Omerect classification, on the left side, there's a clear-cut hip joint synovitis. So what do you think? And there's no evidence of peripheral synovitis. So what do you think? Acute phase reactants are high. So what is the diagnosis? Exactly, the diagnosis is polymyalgia rheumatica. We did the same. So we started the patient on steroids, 15 milligram per day along with methotrexate, had a very good response, and we had a plan to start gradually tapering the steroids. But what happened? Upon tapering the steroids, symptoms relapsed, but now this time involving the small joints of the hand with active synovitis of the wrists, PIPs, MCPs, and now the diagnosis was changed and we made the diagnosis of elderly onset rheumatoid arthritis. So you need to know that approximately 30% of the patients labeled as PMR go on to develop late onset of or elderly onset of rheumatoid arthritis. Briefly, there is a huge list of differences between PMR and rheumatoid arthritis, but remember that in polymyalgia rheumatica, the peripheral joints are extremely rarely involved. They can be involved, but usually they are not involved. This is the ACR criteria for the classification of polymyalgia rheumatica, and this time they have put a list of features through which, through ultrasound, we can pick up biceps tendonitis, tenosynovitis, glenohumeral synovitis. But the point I want to emphasize is that all these findings on an ultrasound can be found in rheumatoid arthritis as well. So it's not that you just pick up the tenosynovitis, biceps tendinitis, or bursitis. You say that we have found the bursitis. Now this is PMR. No, this can be, with the passage of time, can evolve as rheumatoid arthritis. So take-home message from the case number 4 is elderly patients with RA can have an initial presentation mimicking rheumatoid arthritis, and difficult to differentiate RA and PMR solely on ultrasound. PMR rarely involves peripheral joints. Follow-up will definitely help. So keep these patients who are especially presenting in an elderly age, so keep them in the follow-up. Case number 5 is about a 68 years elderly female who has presented with left knee pain and swelling for the last 3 days, and everything was normal on examination. There was a patellar tap was positive, so this was left knee monoarthritis, considering a very old elderly age, although I know elderly age starts at the age of 70, but she's almost touching 70, and she has monoarthritis. What first thing which comes in your mind? We usually think about, so probably the monoarthritis could be because of osteoarthritis. So we did an ultrasound. If you see the line, if you see this is the black line, this is the cartilage. If you see this is on this side, on the lateral aspect is shape, look at the shape, and on that side it has been degenerated. So this is a typical case of osteoarthritis, and when we did a suprapatellar pouch, there was a fluid, and we aspirated the fluid, and assuming that probably this is osteoarthritis with knee effusion, and this was aspirated, and we did the conventional, like most of us do, and but what happened was patient initially felt good, but after 3 weeks the patient developed polyarthritis along with, so that made us think that probably that was the initial presentation of rheumatoid arthritis, and we did ESR and acute phase reactants, and all came out to be positive. And so this is rheumatoid arthritis initially presenting as monoarthritis. So let's see what's the data suggests. Around 10 to 12% of the cases of monoarthritis may progress to rheumatoid arthritis. There is a very interesting paper going to be presented in this conference by, there's a bird registry from Balochistan by Dr. Asad, Muhammad Khan, and Nazir. And they showed the data that around in their cohort, they showed that around 25 to 30% of the patients of rheumatoid arthritis can initially present as monoarthritis or oligoarthritis in the early stages. So the take-home messages from case 5 is there are variable outcomes of monoarthritis. Keep an eye on the evolving symptoms. 10 to 12% of the patients may evolve into rheumatoid arthritis. So this is going to be my last case. And 42 years old female has polyarthritis, and the duration is of 3 months, no comorbidities, and nothing is suggestive of an alternate diagnosis. On examination, the patient has swollen tender PIPs and MCP joints. Acute phase reactants are high, serology is everything negative. Ultrasound clearly shows that the patient definitely have some kind of synovitis. So seronegative arthritis was the diagnosis was made. And we started the patient on methotrexate, steroids, good response, but on the follow-up, the patient developed psoriasis and we changed the diagnosis from seronegative to psoriatic arthritis. So take-home message from the case number 6 is that in 15%, arthritis may precede the onset of psoriasis, and the mean duration was around 8 to 9 years. This was an interesting data which was presented in Annals of Rheumatic Disease back in 2021. So dermatological changes need to be closely observed, especially in patients who are seronegative arthritis. So always keep your eyes open in the seronegative arthritis. Don't assume that they are seronegative rheumatoid always. So the data shows that they can last for up to 8 to 9 years. So I've got a huge list of diagnostic challenges. I won't go into the details. For example, viral infections mimicking rheumatoid arthritis, many other infections, palindromic rheumatism, paraneoplastic syndrome presenting as polyarthritis in initial stages and falsely labeled as rheumatoid arthritis, crystal arthropathies in late stages presenting as polyarthritis, evolutions of arthralgias to arthritis, and sometimes pre-RA to RA. So my conclusion would be that RA is still a clinical diagnosis. Earlier the diagnosis, better is the outcome. History and examination are still the gold standard. One may take help from the serology, acute phase reactants, and imaging as well, but we need to be aware of their limitations as well. Thank you very much.